Hello everyone. Our today's topic is the salivary glands tumor. First of all, the salivary gland tumors that you have to remember that they have a marked morphological diversity and they are highly prone to diagnostic confusion. The benign tumors, they are more common than the malignant tumor. Remember that the benign tumor, they account for the 80% and only 20% are the malignant tumor. So remember, 80% of the salivary gland tumor, they are the benign, and remaining 20% they are the malignant. So 80% tumors, they are benign, and remaining 20% are malignant. Remember that for your entrance exam. Now benign tumor, they can be classified as pleomorphic adenoma, Warthin tumor, oncocytoma, and whereas malignant tumor, they can be classified as mucoepidermoid carcinoma, adenoid cystic carcinoma, carcinoma ex pleomorphic adenoma, acinic cell carcinoma, adenocarcinoma. So these all are the malignant tumor. Now coming to the epidemiology, remember that the benign tumor, they account for the 80% of all the salivary gland neoplasm that we have already discussed. 64 to 80% tumors, they occur in the parotid gland, and malignancy is the rate is in the parotid gland is 15 to 32%, whereas 7 to 11% they occur in the submandibular gland and less than 1 occur in the sublingual gland. There is a rule of 80 that you have to remember, that 80% of salivary gland tumors, they occur in the parotid gland. 80% of the parotid tumor, they are benign. 80% of the parotid tumor, they are a pleomorphic adenoma. 80% of the parotid pleomorphic adenoma, they occur in the superficial lobe, and 80% of the untreated pleomorphic adenoma, they remain benign. So remember this rule of 80. So we discussed that tumor, they can occur from the major salivary glands. What are those? Parotid, either submandibular or either sublingual. Apart from that, they can be seen from the accessory salivary glands like seen in a lip, palate, buccal mucosa, etc. Now, what are the etiological factors? Let us discuss that. The first being the radiation exposure. Now we know that the radiation therapy has been used for treating conditions like acne, benign head and neck tumors, that was found to be having increased risk factor for developing salivary gland tumors. The ionizing radiation would cause a DNA damage that could lead to further mutations, and hence they can cause tumor formation. So a higher incidence of salivary gland tumor in patients who received radiation therapy had been seen. The second is genetical predisposition. Some families have higher incidence of salivary gland tumor, suggesting a hereditary component. Specific genetic mutations and alteration like those found in tumor suppressor gene and oncogenes, they have been associated with the salivary gland tumors. So remember that. Other is the tobacco smoking. So remember, the use of tobacco, particularly smoking, has been linked to increased risk of salivary gland tumors. Other is chemical carcinogens. Exposure to certain chemicals in the workplaces, they have been associated with the high use of the salivary glands tumor, as like the asbestos, rubber manufacturing, and certain pesticides, they have been implicated. Certain chemicals like the nickel compounds, silica dust, they have been associated with increased risk of the salivary gland tumor. Apart from that, viruses, development of certain viruses like the human papilloma virus, HIV, HPV, they all are associated with the salivary gland tumors. So remember that radiation exposure due to the increased risk, the radiation exposure occur due to the increased risk due to the DNA damage, genetic predisposition, that could be family cause, and specific genetic mutation that could lead to salivary gland tumor. The third is tobacco smoking. Tobacco smoking can be they have a direct carcinogenic effect from the smoking. Chemical carcinogens, occupational exposure to harmful chemicals, and viruses like oncogenes, and viruses like Epstein-Barr virus and human papilloma virus, they can be associated with the salivary gland tumors. Now let us discuss about the pleomorphic adenoma. So remember, the most common of all salivary gland neoplasm is the pleomorphic adenoma. Which tumor is found in the pleomorphic adenoma is found in 80 to 90% of the parotid gland, and in the minor salivary glands it occurs in the palate, upper lip. It occurs in 4 to 6 decades of life, and it occurs more commonly in the females. Apart from that, it occurs in age of 40 to 60 years of age. This one is the pleomorphic adenoma, as you can see here. It occurs mainly in the lower part of the superficial lobe of the parotid gland, that you have to remember for your exam point of view. Apart from that, it has both the ductal as well as non-ductal epithelial components. It also includes the mesenchymal cells, the mesenchymal components that are the chondroid, that is the cartilage, myxoid, that is a mucoid, and osseous component, that is the bone. So remember other name of pleomorphic adenoma, it's the mixed tumor. So due to the fibrous hellenized myxoid and myxoid types and the osseous types, these tumor, they can show metaplasia, that is they can transfer into one cells into the another. That is why that is known as a mixed tumor. So its unique ability to differentiate into multiple cells, that is its main characteristic feature. So it has a myoepithelial cells. So these are the myoepithelial cells. They resemble spindle-like cells. That are the main cells. Other cells are intercalated duct reserve cells. They can differentiate into both the ductal and non-ductal cells. The non-ductal cells are the myoepithelial cells, which can differentiate into mesenchymal cells, and these mesenchymal cells can differentiate into various cartilage, mucoid or bone variants. So pleomorphic adenoma, remember it is the most common tumor of the salivary glands that affect the parotid gland. It can occur in major and minor salivary glands, more commonly seen in the females, and parotid gland, that is the most commonly it is seen in the lower part of the superficial lobe of the parotid gland. Clinically, you will see the tumor is firm with irregular borders and cystic generation. Pain is rare, but local discomfort can be seen. Macroscopically, pleomorphic adenoma typically presents as irregular to ovoid marks with well-defined borders. It has an incomplete fibrous capsule or it is unencapsulated. The principal cells, they are the myxoid and cellular components. So it can appear as a duct form, neft form, sheet form, and foci of keratinizing squamous or spindle cells. The myoepithelial cells, they contribute to mesenchymal-like changes in the tumor that is characterized by excessive accumulation of mucoid in the material. The treatment part. Well, the treatment part of the pleomorphic adenoma, remember the treatment part is the surgical excision. So the surgical removal of the tumor is the main goal. So we know that most of the tumor it arises from the superficial lobe. That is why a superficial peridoctomy is recommended. Remember the radiation therapy is contraindicated as the tumor it's radio resistant. So making the radiation therapy ineffective. What are the complications that you can see is in the rare case, the pleomorphic adenoma, it may transfer into a malignant tumor. That the term we use is carcinoma x pleomorphic adenoma. So remember the surgical excision, it's the gold standard. It's the gold standard for the treatment of the pleomorphic adenoma. The next tumor that we are going to discuss, it's the Warthin tumor. What is the other name of Warthin tumor? Remember, it's papillary cyst adenoma lymphomatosum. Which tumor is, remember, second most tumor after the salivary glands? It's the Warthin tumor. Which tumor it's most common in the males? It's again the Warthin tumor. Which tumor it's associated with cigarette smoking? It's again the Warthin tumor. Which tumor exists in the parotid gland or the parotid tail? It's again the Warthin tumor. So remember, the most widely accepted theory suggests that the Warthin tumor, they arise from the salivary glands within the paraparotid lymph nodes or interparotid lymph nodes during the embryogenesis. Apart from that, you have to remember is that it occurs more in the males, already discussed, more common seen in the smokers, seen in parotid gland. Now let us discuss what are the microscopic features that you would see in the Warthin tumor. So remember, the microscopically you will see it is characterized by a double layer of oncocytic epithelium. Lining cyst spaces. So these are the cystic spaces that contains double layer of the oncocytic epithelium that are lined by the lymphocytic stroma that will contains the germinal centers. So again, the treatment part is the surgical excision. Remember, it has the tumor, it has a bilateral oncocytic epithelium. It has inner cell layer, that is, the inner cell layer are the tall columnar cells with eosinophilic cytoplasm, and the outer cell layer there is oncocytic epithelium with fusiform basaloid cells. So the treatment, remember the treatment is the surgical excision. So the prognosis for the Wathin tumor is generally excellent following the surgical excision, given it has a low reoccurrence rate and it has a minimal risk of malignant transformation. The next tumor is it's the oncocytoma, or other name is oxyphilic adenoma. So it is a rare 1% of the benign salivary gland tumor. Remember, oncocytoma, they are rare benign salivary gland tumor. They are primarily found in the parotid gland. Despite their small size and clinically similar to other benign tumors, they are distinguished by the unique characteristic. They have oncocytes that are rich in mitochondria. It's seen more in the females, predominantly seen in the elderly individuals, with 80% of the cases presenting between the age of 50 to 80 years. So it appears as a discrete encapsulated mass. It's generally painless. Seen in parotid submandibular gland. The treatment of choice is the surgical excision. So remember, oncocytes, they are arranged in the form of sheet, nest or codes. Here, the tumor has little sportive stroma. Lymphoid tissue may be frequently present. On ultrasound, on the ultrastructure, you may see oncocytes. They are engorged with enlarged mitochondria that contribute to the granular appearance of the cytoplasm. Now let us discuss about the malignant neoplasm of the salivary glands. First of all, they have a shorter duration. Malignant neoplasm often present with a shorter duration of symptoms compared to the benign tumors. These tumors, they have a rapid growth, so they grow rapidly. Malignant tumors, they tend to be fixed to the surrounding tissues. Unlike the benign tumor, they are usually mobile. There might be skin or mucous membrane ulceration that can also invade that may be ulcerated or show sign of inflammation. Surface telangiectasia may be present. There may be small dilated blood vessels on the surface. A nerve involvement. Malignant tumor can invade nearby nerves, leading to symptoms like pain, numbness, or even the facial paralysis. The presence of enlarged lymph nodes, they can suggest metastasis, where the malignant cells, they can spread from the primary tumor to the nearby lymph nodes. Now let us discuss about the malignant neoplasm. The first is the mucoepidermoid carcinoma. Remember, it's a malignant epithelial tumor that consists of mucus secreting cells as well as, so it has a mucus secreting cells as well as epidermoid cells. So remember, the most common malignant tumor of both major and minor salivary glands, it's the mucoepidermoid carcinoma. It represents 29 to 34% of the malignant salivary gland. Remember, seen mainly in the parotid gland. On intraorally, the location would be palate. The most common site is palate. Female prediction primarily occur in 5th decade of life with average lifespan of 47 years. So the tumor, it may have show growth, maybe painless or painful mass. They can grow rapidly and infiltrate the surrounding tissue. Ulceration may be seen, nerve involvement could be seen. That are the features. So mucoepidermoid, it produced mucin producing cells and epithelial cells of epidermoid. It can be classified as low grade, intermediate grade or high grade. Low grade is slow growing, high grade is rapidly growing. So low grade appears as slow growing painless mass. It does not exceed 5 cm. Unlike the pleomorphic adenoma, it is not completely encapsulated. Whereas the high grade, it grows rapidly, producing pain early in the early involvement of pain could be seen frequently, causes facial nerve paralysis. There may be trismus, drainage from air, numbness in the adjacent areas, etc. That could be the feature. Now, what could be the microscopically you would see is the mucin. The low grade tumor, they are well formed glandular structures with prominent mucin filled cystic spaces. Mucin filled cystic spaces. Minimal cellular atypia with high proportion of the mucous cells. In intermediate grade, you would see epidermoid cells with intermediate baseloid cells, whereas in high grade you will see solid nest and codes of baseloid and intermediate cells. So that the high grade has a higher mitotic activity, prominent nuclear pleomorphism, exhibit perineural invasion, etc. These are the main features. The treatment is conservative excision. Prognosis is less favorable to low and intermediate grade tumors. Higher risk of reoccurrence in regional and if there is distant metastasis. Next, moving to adenoid cystic carcinoma. What is the other name of adenoid cystic carcinoma? Remember, it's also known as slendronoma or basal. It is also known as slendronoma. It is the second most salivary gland malignancy. So what are the clinical features? There is perineural spread. It infiltrates widely into the tissue planes, commonly seen in the submandibular gland. So it shows aggressive behavior. So slow growing, allowing it to spread extensively before the symptoms become apparent. Now the histological variants, that could be various forms like cribiform, tubular, solid and cystic. Remember, the salivary glands, they are most affected. Parotid glands could be affected. It occurs in 5th to 6th decade of life. Females are most common affected. Pain may be seen, early pain, fixation and invasion. It tends to fix to the deeper tissues. Ulceration may be seen. and the main feature is it spreads through perineural invasion. What does perineural invasion spaces means? That the adenoid carcinoma it has a property to invade and infiltrate and extend along the nerves within the body. So that means perineural invasion means spread of cancer cells along the nerve pathway that can facilitate the tumor to adjacent tissue and potentially spreads the distant sites. So three forms that have been predicted, they are the cribiform, tubular, solid. The cribiform, that is the most common form is the cribiform. So this one is the cribiform. It features basaloid epithelial cell nest forming cylindrical cyst-like patterns resembling Swiss cheese or honeycomb pattern. Other is the tubular variety that consists of stratified cuboidal cells, and third is this one is the solid pattern that shows solid group of cuboidal cells with a little tendency to form cyst formation. The treatment consists of surgical excision. In some cases, surgery may be combined with the X-ray radiation. Radiation alone is not recommended as standard treatment. Next, moving to the acinic cell carcinoma. Remember, acinic cell carcinoma is a malignant tumor that arises from the salivary glands, showing differentiation toward the acinar cells that are responsible for excreting the saliva. Now, this acinic cell carcinoma, it originates from the epithelial cells of salivary gland duct. So these tumor cells would represent characteristic that resembles the acinar cells. These acinar cells, they are responsible for excreting serous fluid, that is a component of saliva. So these cells they will contain zymogen granules that are the specialized structure involved in production and excretion of enzymes. So acinic cell, remember, it's the third most malignant epithelial neoplasm of the salivary glands. The first was mucoepidermoid carcinoma, second is adenocarcinoma, and third is the acinic cell carcinoma. So it consists of 6 to 8% of all salivary gland malignancy occurs mostly in the parotid gland. It has a low grade behavior and 3% of them shows the bilateral involvement. The acinic cell carcinoma often represents like a pleomorphic adenoma in its gross appearance. It occurs in the parotid gland about 80% of the cases. It can also occur in the younger individuals before the age of 20 years. Females, they are affected more as compared to men with a ratio of 3:2. So in acinic cell, remember there is a differentiation toward the acinar cells. Now the histological features, what you would see in the histological features, they consist of cells with varying degree of differentiation. The well differentiated cells resembles normal acinar cells, whereas the less differentiated cells, they represents The left differentiated cells resembles the embryonic duct or the immature acinar cells. So there are four main growth patterns: solid, papillary cystic, follicular, and microcystic. So the most characteristic cells that are seen in acinar cells, they resemble the serous acinar cells with abundant granular basophilic cytoplasm and vacuolated cells. So these, you can see the vacuoles that are unique to the acinic cell carcinoma. So the cells resemble serous acinar cells that are abundantly granular basophilic cytoplasm and shows a eccentric nucleus. The nucleus is on one side. The stroma, the connective tissue stroma that surrounds the tumor, is fibrovascular, and lymphoid elements, they not be found. Clear cells, so this figure represents, they have a moderately well defined acinar cells that have a uniform dark round eccentric nucleus and basophilic cytoplasm. The next is the carcinoma X pleomorphic adenoma, the most common subtype of malignant mixed tumor that arises from the salivary gland. It's the carcinoma X pleomorphic adenoma. It occurs in the major salivary glands, with the parotid gland being the most common site, followed by the submandibular gland and the palate. So this one is the risk of a malignant. It presents in individuals with 6 to 8 decades of life, with average life of 10 years older than those with the pleomorphic adenoma. So on histopath, you will see poorly circumscribed infiltrate, hard mass, malignant cells that are seen adjacent to typical appearing pleomorphic adenoma. Other type is polymorphous low grade adenocarcinoma. So remember, it occurs in the minor salivary glands and is the most common benign and malignant salivary gland neoplasm, following the pleomorphic adenoma and mucoepidermoid carcinoma. So it occurs, most tumor occur in the mucosa of the hard palate or the soft palate. So the patient represents with the firm non-tendernous swelling in the mucosa of the hard and soft palate, cheeks, upper lip, etc. So on histopath, you will see infiltrative growth with the diverse morphology. The tumor, it undergoes various growth factors like growth patterns included solid, ductal, cystic, or the tubular form. So cells, they are cuboidal to columnar with ovoid to spindle shaped nuclei, and there is a moderate cytoplasm. The treatment is surgical excision, radical excision, neck dissection with the lymph node involvement. These are all the treatment part. The next is the salivary duct carcinoma. It is a rare, typically high-grade malignant epithelial neoplasm that is characterized by structures that resembles the expanded salivary gland ducts. So neural invasion and extraglandular extensions, they are common. Infiltrative tumors element could be seen invasion of nerves, blood vessels, salivary glands, structures like fat, muscle, bone. It is frequent. The treatment is local excision with a radical neck dissection and a post-operative radiation therapy that could be the most benefit to the patient. Next comes is the adenocarcinoma. They are rare but aggressive tumors. They occur in patients above the 40 years of age, and equal frequency it occurs in men and women. Half of them tumors occur in the parotid gland. Minor salivary glands tumor, they can occur in palate, lip, tongue, etc. So on histo you will see firm mass with irregular borders and infiltration into the surrounding tissue. So they can be described as grade 1, grade 2 or grade 3. Remember, grade 1 have well formed ductal structure, grade 3 have more solid growth pattern. So treatment is aggressive due to its aggressive nature. Lymph node metastasis is not common, and in case where there is palpable neck disease, neck dissection can be considered. Now for the salivary gland tumor, remember the duration of mass that would help to determine if it's a recent development or a chronic issue that can provide insight into the potential underlying cause. The rate of growth may suggest aggressive pathology, while a slow growth represent a benign condition. Presence of pain that can indicate inflammation, infection, or compression of the nearby structures. Facial paralysis may indicate involvement of the facial nerve. The most common nerve is the 7th cranial nerve, originating from the parotid gland, or there could be bilateral facial paralysis that is less common. Apart from that, cervical lymph nodes may be enlarged, that can indicate the spread of the inflammation. There could be symptoms like visual disturbances or eye pain, may suggest neurological involvement or systemic condition that may affect the blood vessels. So these things are important for the evaluation for the patient. Other thing that you can assess is the size of mass, palpating it to determine its dimension. So that helps to know the extent of the tumor and what are the changes that occurs over the time. Examination of overlying skin, whether it is red, ulcerated, that may indicate involvement of skin by the tumor. You can also check the skin fixation, whether there is adherence of skin to the underlying mass that can suggest the infiltration of the surrounding tissues. You can check the mobility of the mass, whether it's by gently palpating it to determine whether it is freely movable or fixed to underlying structures. Enlarged lymph nodes may indicate metastasis or active changes that may occur secondary to the tumor. Assessment of the cranial nerves that can be considered, and intraoral examination that can be done, including the palate, buccal mucosa, examining them. That can be done. Now let us discuss the other condition, mixed tumors. One is the salivinosis. What is that? Remember, it's a known neoplastic, non-inflammatory enlargement of the salivary glands, especially the parotid gland. So there is bilateral enlargement that is associated with the systemic disorders, and there is chronic painless enlargement of the salivary glands, particularly the parotid gland. Apart from that, there would be due to the non-inflammatory enlargement of the salivary glands, uh, there is decreased salivary secretion, and there would be increased potassium and decreased sodium level. The most important feature is in cellulinosis. You will on cellography you will see leafless tree pattern, like a tree pattern that is without its leaves. Now, what would be the treatment of this? The treatment, it focus on correcting the underlying cause, correcting the systemic disorder like alcoholism or the diabetic mellitus. Subtotal peridectomy may be considered as last resort. The next condition we are going to discuss, the next condition is necrotizing cyalometaplasia. So it is, remember again, a non-neoplastic. It is a non-neoplastic inflammatory condition of the salivary glands. So it histologically resembles squamous cell carcinoma or mucoepidermoid cell carcinoma. So it is believed that vascular ischemia is the main factor. So the vascular ischemia, remember, it's the main factor that is responsible for developing the necrotizing cyalometaplasia. It mainly involves the salivary glands of the oral cavity, particularly those of the palate, and it can also occur in retromolar pad, buccal mucosa, tongue, etc. Now histologically what you will see is features like coagulative necrosis of the glandular acini and the squamous metaplasia of the duct that you would see. So the most important feature is a pseudoepitheliomatous hyperplasia of overlying mucosa. The treatment, it resolves spontaneously and no specific treatment is required. The other condition is, remember, Mikulicz disease. So it's a condition where there is abnormal enlargement of the salivary glands as well as the lacrimal glands. So there is bilateral lacrimal gland involvement with the salivary gland involvement. It's more common in females and it may occur in association with the Sjogren syndrome. The symptoms include xerostomia, difficult swallowing, tooth decay, tears due to enlarged lacrimal glands, and painless swelling of the salivary glands. Histologically, you will see lymphocytic infiltration of the salivary glands, destroying the acini with island of the residual epithelial cells. So eosinophilic hyaline material deposit in epithelium island, it's a characteristic feature in the advanced cases. So the treatment, it's Remember, the treatment for the Mikulicz disease is symptomatic, focusing the associated symptoms, artificial tears that may be given that may help to alleviate the dry mouth symptoms, and with the salivary glands enlargement. Other condition is the Sjogren syndrome. So Sjogren syndrome is also known as, remember, Sika syndrome, and it is characterized by triad of the three triads are dry eyes, that is keratoconjunctiva, Sika, xerostomia, dry mouth, and rheumatoid arthritis. So the patient may present only with the dry eyes and dry mouth and may develop autoimmune conditions like SLE, scleroderma, etc. So the alteration in the immune system, its main role that plays, it affects the females. There is dryness of mouth, eyes, decreased function of the salivary and the lacrimal gland. So in cytochemistry, that reveals elevated level of IgA, potassium and sodium in the saliva. The secondary Sjogren syndrome is associated with the rheumatoid arthritis. So three types of histological alteration in the major salivary glands. On histological, you will see lymphocytic infiltration that replace the acinar structure along with the formation of myoepithelium that forms the epimyoepithelial islands. So the treatment, keratoconjunctivitis, is managed by the ocular lubricants. For xerostomia, you can give is the saliva substitute. Surgery may be considered for symptomatic salivary gland enlargement, and radiation therapy is generally not recommended. Other is chronic sclerosing sialadenitis of submandibular gland, that is also known as Kuttner tumor. So it is a benign inflammatory condition that can mimic malignant neoplasm due to presentation as hard mask. So there is thickening of the interlobular septa by the sclerotic tissue. The treatment is antibiotic therapy or rehydration in order to stimulate the salivary flow. Surgical drainage may be necessary in case of the abscess formation.